Hi, I'm Ajay Nooka. I'm the director of the Myeloma program at Emory University. I presented the efficacy and safety of Elranatamab in patients with relapsed refractory multiple myeloma and prior B-cell maturation antigen-directed therapies, a pooled analysis from the MagnetisMM studies. Elranatamab is a humanized bispecific antibody that targets both the BCMA-expressing myeloma cells and the CD3-expressing T cells. Data from the ongoing phase 2 MagnetisMM-3 study was demonstrated the efficacy and safety of Elranatamab as monotherapy in BCMA-naive patients with relapsed refractory myeloma. This was presented at ASCO of 2023 as a poster and at a data cutoff with a median follow-up of 14.7 months. The overall response rate was 61%. The median duration of response has not been reached, so is the median PFS. The efficacy and safety of Elranatamab monotherapy in patients with relapsed refractory multiple myeloma and a prior exposure to BCMA-directed therapies, whether it's a CAR-T or an antibody-drug conjugate, was evaluated in a pooled analysis of 4 MagnetisMM studies. The 4 studies included MagnetisMM-1 study, which included 13 patients, MagnetisMM-2 study, which included 1 patient, and MagnetisMM-3, where majority of the patients were included in this pooled analysis. This study evaluated the dosing of 76 milligrams subcutaneously given weekly with 2 step-up doses of 12 milligrams and 32 milligrams. The other study that included 9 patients was the MagnetisMM-9 study. The efficacy endpoints were assessed by the investigator by the IMWG criteria, and all the patients who were eligible received at least 1 PI, 1 IMiD, 1 anti-CD38 monoclonal antibody, and 1 BCMA-directed therapy, either it's an ADC or a CAR-T. This pooled analysis included a total of 87 patients. So among these 87 patients, 59 patients received a prior ADC and 36 patients received a prior CAR-T. The median age is younger or lesser among patients who have received a prior CAR-T, which included the cohort of 36 patients. As expected, this cohort is younger and had high-risk cytogenetics seen in 30% of the patients, compared to those patients that received a prior ADC having 22% of the patients with high-risk disease. Extramedullary disease was seen in close to 50% of the patients in this cohort. 8 patients received both prior ADC and prior CAR-Ts. So if you look at the prior treatments, the median prior lines of therapy were 7 overall, and these were 8 in the prior ADC arm and 7 in the prior CAR-T arm. If you look at the penta-drug refractory status, these were 83% of the patients in the prior ADC and 91% of the patients in the prior CAR-T were penta-drug refractory. If you look closely at the patients who were hexadrug refractory, that means in addition to the penta-drug refractory status, who had a prior BCM exposure, that accounts to 40% in both these studies. So this is a heavily pretreated patient population. And at the data cutoff, the median duration of follow-up of 11.3 months, 20 patients, which is 23% of the patients, continue to receive ongoing treatment. And the major reason for the treatment discontinuation was progressive disease. Objective response rate was seen in 46% of the patients in this entire cohort, and those patients that had a prior CAR-T treatment had a higher numerical value, which was 52.8%, and prior ADC treatment patients received an objective response rate of 42.4%. Durability of the responses among those patients that responded and continue to respond, 20 of the patients continue to respond, and these responses are ongoing. Duration of the response among patients who had received a prior BCMA-directed therapy was 17.1 months, and prior ADC was 13.6 months, which has not been reached among patients that received a prior CAR-T. The PFS for the entire cohort was 5.5 months. For those that received a prior ADC was 3.9 months, and interestingly, for those patients that received a prior CAR-T was much longer at 10 months. Overall survival for the entire cohort is slightly over a year mark. So coming to the safety profile, most of the toxicities that were seen were hematological, and these common treatment-emergent adverse events were infections, cytopenia, and CRS were similar to the BCMA-naive patient population of the MagnetisMM-3 study. The treatment-emergent adverse events led to death in 23 patients, 11 due to disease progression, 8 due to infections. The non-hematological toxicities, as expected, were higher in the CRS as well as diarrhea. Let's focus on the areas of special interest, which are the infections. Infections were reported in 73.6% of the patients, and majority of these were grade 1 infections, grade 1 or 2 infections, and grade 3 or 4 infections occurred in 26.4% of the patients. The COVID-19 related treatment emergent adverse events were reported in 25% of the patients. Coming to the CRS and ICANS, majority of the reported CRS events occurred with the priming doses of the cycle 1 day 1 and cycle 1 day 4, and these have declined with further dosings. And most of these are grade 1 or grade 2, with grade 3 events occurring in 1% of the patients. And tocilizumab was given in 21.8% of the patients, and steroids were given in 11.5% of the patients. And the median time to onset of CRS was 2 days, and median duration was 2 days. Similarly, the median time to onset of ICANS was 2 days, and median duration was 2 days. To conclude, Elranatamab as monotherapy was efficacious in patients with relapsed refractory myeloma and prior exposure to BCMA-directed therapies, whether it's ADC or CAR-T. The response rates were seen in close to half the patients. The median duration of the response among the responders was 17.1 months, and the median PFS was 5.5 months for those patients that received prior ADC, and median overall survival was slightly over a year. These results support that elranatamab monotherapy as a treatment option for patients with relapsed refractory myeloma post BCMA-directed therapy, and the safety profile was consistent to the patients who are BCMA-naive. Thank you.